Okay, dear colleagues, let's start. Good morning. My name is Dementeva Yulia Nazimovna. I am senior lecturer of the Department of Pediatrics. Let me introduce to the wonderful world of pediatric. We will, during our lecture course, we will discuss some disease. Also, we'll discuss development of and growth and length for growth child. Also, we'll discuss some new information for postnatal care. Today's lecture, our first lecture, will be for introduction of to pediatrics, and also we'll discuss history, pediatric history. Just a minute. Okay. Let's start. Our department, we have two basic, two hospitals where our department are based. It's it's Regional Children Clinical Hospital, Department of Pediatrics. Look at this, it's Radisheva Street 42. This one, the fifth row. Also our telephone number, and also we are based in City Clinical Hospital number 1, Surva Street, and the fourth, and also our we can you can find our room, classroom at the second floor. Also, let me introduce our department. We have some professor of pediatrics. It's Slavyova Irina Leonidovna, Kulsiman Alexey Isevich, Черданцев Alexander Petrovich, and Galaktionova Marina Yurievna. Also, we have associate professor, Department of Pediatrics. It's Saponi Yuri Nikolaevich, Derebina Elena Viktorovna. Also, senior lecturer Dementeva Yulia Nazimovna, it's me, and Prudskova Ekaterina Vladimirovna. And our assistants, they are Kafarova Alexandra Igorevna, Kadyrova Yulia Albertovna, and Feyzer Albina Albertovna. You will meet some of our professors and associate professors during lecture course and during exam, and senior lecturer and assistant you will meet them during the practical classes. Also, we will, if we will work offline, you will attend child hospitals, and you will need some medical documents, and you should have access from therapists and some clinical and instrumental tests. You can see them, and it's very important to have a permission from therapist in order you will be able to attend your patient offline. Okay, it will just our introduction, and our first lecture is Pediatrics History Taken, and we will discuss during this lecture how to write pediatric history and how to work with pediatric group of your patient. Okay, as for history, you should discuss some history questions. First group is identification, name of baby, age and date of birth, gender, blood group, and information about parents. Information about parents sometimes is very important. Age, occupation of parents, also some information will give you some key points for history. Also, you should fix date of admission, date of examination, and some chief complaint. Mention of the main reason that brings the patient to the hospital, up to chief complaint, and it's very important fix all important complaint during your conversation, and duration of chief complaint. Also, the very important information, it's a history of present illness. You should fix this information. Last time the patient was well, the story, pay attention to the story, take it from the source like the mother, ask her to tell you the full story, then summarizing and writing her words, but you should let me say, retranslate her just normal words, some just usual speaking to the medical term. And you should analyze this of the symptoms, complete the same system, relevant systems, ask about any system related to the involved system. Also, you should ask routine questions like fever, sweating, urine output, feeding, activity, sleep, weight loss, some admission, ask about investigation, treatment, improvement or not, and some new event that may occur during hospitalization. For example, it was hospitalization with just some surgery operation, but some maybe flu or some other virus occur with a patient, you should fix them. It will be the new disease, or maybe it's some maybe transformation of feeling of patient feeling during the hospitalization. It's also very important fix not only complaint for just before hospitalization, and you should fix all information during hospitalization. Also outcome, the condition of patient at the moment of taking history. Also you should fix key points in pediatric history and examination. Very important, the child's age. A key feature in the history and examination is determines the nature and presentation of illness, developmental or behavioral problems, the way in which the history taking examination are conducted, the way in which any subsequent management is organized, and the parents who are astute to observe their children never ignore or dismiss what they say. For example, your patient is adolescent, teenagers, your patient, and you discuss only information with your just teenage patient, but some new and very important can be explained for you. Then you will have a discussion with parents, and also sometimes nanny or just grandparents also will help you. For example, parents just stay maybe half of the day at work, and your patient stay at home with grandma, for example. That's more important information you will take with from the dialogue with just grandma. Also, you should pay attention to the age of your patient, because your maybe dialogue, your conversation will vary during the conversation with your parents. Just a minute, I will ask you, is my speaking okay? You understand and the loud of my pronounce is okay? Just to read some information, and I will just transfer to my once again transfer to the lecture. my pronouns all in just video is okay. You can see all just pictures. Okay, if no problem, just once again we'll just go. Okay, why the age of your patient important? For example, your patient is infant. You will discuss with patient mother, and also it's highly important discuss all antenatal, postnatal and internatal information. Your patient is toddler. Also, the development, postnatal, antenatal information is very important. Your patient of preschool age, also pay attention to the development, feeding history. For example, your patient is school age, also very important information for the just very important information during the school age, some just extra school activity. Also, your patient of teenagers maybe not so important postnatal, antenatal, intranatal, but it's vice versa, depend on the just disease. But for example, for flu, it's not highly important, maybe antenatal care for just teenagers. The illness and problems children encounter and highly age dependent, as we discussed. And the child's age will determine the question you ask on history taken, how you conduct the examination, the diagnosis and differential diagnosis, and your management plan. For example, pneumonia. The etiological factors will depend on the age of your patient. Also, some etiological factors, typical and atypical, varies during your patient age. Okay. First of all, your introduction between the history taken. Make sure you have read any referral letter and scan the notes before the start of the interview. Observe the child at play in the waiting area. For example, if you have some time just at the normal activity, observe appearance, behavior, how child communicate with parents, and continue observation of child during the whole interview, and it will provide important clues to the diagnosis and management. When you welcome the child to parents and siblings, check that you know the child's first name and gender. It's very important, and ask how the child prefers to be addressed, of course for teenagers, school age and preschool. Determine the relationship of the adults to the child. As for Russian Federation, at the just hospital, the parents, we can have conversation only for the parents, because they legally can just be just have all legally just permission to just communicate with medical with doctors. Sorry. Establish eye contact and report with the family. Infants and some toddlers are more secure in parents' arms or laps. Let parents hug and just you can examine at the just parents' arm. Ensure that the interview environment is as welcoming and unthreatening as possible. Avoid having desks or beds between you and the family, but keep a comfortable distance for you and also for family. Have toys available. Observe how the child separates play and interacts with any siblings present. Do not forget to address questions to the child when it's appropriate, of course. There will be occasions when the parents will not want the child present or when the child should be seen alone. Of course, if you examine teenagers of appropriate age, for Russian Federation it's 15 and high, you can examine without parents, but first of all you should ask permission and examine teenagers. If it's examination without parents, it's better to use maybe some supporting, maybe some nurse or the other doctors will also stay near you and you not be alone with teenagers. Okay, adapting to the child's age. Adapt the examination to suit the child's age. While it may be difficult to examine some toddlers and young children fully, it's usually possible with just imagination of the doctor's part. For example, babies in the first few months are best examined on an examination couch with parents next to them. Toddler is best initially examined on his mother's lap or occasionally over a parent's shoulder, or if it's just normal, you have just a normal atmosphere and toddlers just is understand that you will just examine without any panic from toddlers side. You can examine on examination couch also. Parents are assuring for the child and helpful in facilitating the examination if guided as to what to do. Preschool children may initially be examined while they are playing, but also you can just use examination couch or just mother's lap or just mother's hand. Also, all the children and teenagers often concerned about privacy. Teenage girls should normally be examined in the presence of their mother or a nurse or a suitable chaperone. Be aware of cultural sensitivities in different ethnic groups. It's very important for just we have some. We should ask some permission or some maybe just male doctors doing some ethnic groups. Very important, and ask permission for parents, for teenagers, and not to forget about cultural sensitivities in some ethnic groups. This is example how distracting a toddler with a toy allows auscultation of the heart. Just mom hug the baby and child play with toys, and you just see it and auscult, and you just can auscultate your just patient. Okay. Now we will discuss some key points of history, and we will just explain. I will explain it for you. It's better maybe to fix some red flags or some key points, but you will have the recording of this lecture on our YouTube channel. Also you can repeat, but as for me it's better to fix using our writing memory also. Okay, prenatal and antenatal history information should be attend regular visits, take folic acid and supplements. So you should discuss with mom all antenatal care. Also, you should point and just fix all mother's disease during the pregnancy. just the most important torch infection is Toxoplasma, herpesvirus, rubella, cytomegalovirus. Just a minute. Torch, it's toxoplasm, other rubella, cytomegalovirus, herpesvirus, but also HIV, chickenpox, hepatitis, also important, and some tertiary infection appears fever and skin rash and joint swelling can cause some very important condition. For example, we have some congenital, as an example, congenital rubella syndrome, microcephaly, some congenital heart disease and cataracts. That's why we pay attention to the torch, because sometimes mom can just explain for her just some small rashes and some just fever. It's like a flu and allergy, for example, for some maybe syrups, but it was, for example, rubella, and it will be just the reason for congenital rubella syndrome. That's why pay attention for all diseases during the pregnancy. Also, the very important information is drugs taken during the pregnancy. The classical example for this is just situation when with thalidomide, it's caused very just thalidomide was the reason for serious congenital deformation of just arm and legs. That's why you should pay attention for the drugs history. Exposure to radiation during pregnancy, also fix some situation when CT and X-ray examination was prescribed for pregnant women. Smoking, bleeding, previous abortion and neonatal death, admission to hospital for any reason, vaccine and number of child. And also important information is just the period between pregnancy, because if it's pregnancy after pregnancy with a small period between them, it's also important, for example, for rickets, for just iron deficiency anemia, for hypertrophy. That's why pay attention for number of child, and also pay attention for the this information, just the number of child, and also how many years between the pregnancy. Okay, natal information. Place of delivery, at home or hospital, it's very important. Type of delivery, vaginal or cesarean section. If cesarean section, what is the indication? Elective or emergency? Duration of delivery, normal or prolonged? Any complication during labor? Instrument use in the delivery? Gestational age, preterm or term or post-date or post-term? Weight of the baby, normal, small, large, gestational age, and Apgar score. This information is very important. You should fix, and after that analyze this information. Postnatal care, neonatal period, first 28 days of life, immediate crying, time of discharge from the hospital, 24 hours, 84 hours or more. As for Russian Federation, we have just the women with newborn baby stay at hospital. It's normal for 4 or 5 days. As for other countries, maybe at only 24 or 48 hours. National Intensive Care Unit, NICU admission. What was the reason for NICU? When the baby passed urine within first 24 hours, and meconium, the first two, within first 84 hours, because the situation then it was passport for meconium. It can be the cystic fibrosis, and it will be the red flags. The passported meconium will be just the red flags. Movement, natal Jordans, cyanosis, fetal distress, feed bleeding, baby developed other disease, treatment. For first 28 days, it's a neonatal period. This information is very important. It's better to fix, so to just try to fix from the medical documents, or just ask all information from during the conversation with your patient's mom. Okay, past medical history, previous similar disease, previous admissions, chronic disease, previous infections, measles and other. Pay attention to the child disease, rash infection, just other group of infection. For example, whooping cough, or just mumps, measles. Also, you should pay attention to the blood transfusion, past surgical, previous operation, indication, type, outcome, circumcision in male and ear piercing in female, at which age, any complications. Because some information like first symptoms of maybe some problems with bleeding system like hemophilia, you can take from the complication of circumcision, hospitalization, drug history, drug taken by mother, the reason was chronic use, drug taken by baby, also the chronic use, and allergy to drug and other substances. You should fix what the allergy condition it causes, and fix this information in medical history. Okay, feeding history, very important for pediatric history taken. Breastfeeding, way of feeding, using both right and left breast each feeding time, or just one by one. Regular, at least every 3 hours on demand. Any problem with feeding, latch nipper, just some other reason, bottle feeding, way of preparation, type of formula use, lactose-free, soy milk formula, and just amino acid formulas, or it can be carb protein or GAR protein formula. Way of sterilization of the bottle, boiling, washing, brushing, or no sterilization, and it will be the reason for acute diarrhea. Number of bottles, number of feeding, regular, at least every 3 hours or on demand. For example, some problem with weight can be the reason with only you can find all the reason with weight problem only during the discussion feeding history. Any problem occur after bottle feeding, diarrhea, vomiting, the other reason. Put the bottle in freeze for cooling. Mixed feeding, breast and bottle feeding are the same, only on demand, or every feed they combine breast and bottle feeding. Semi-solid or solid food, at which age given, type, complementary feeding, age, products, also very important for weaning, at which age milk was taken off his diet. Ask the child eats soil, food, or other things caused by iron deficiency, anemia, calcium deficiency, lead poisoning. That's why discuss all feeding history. Try to fix red flags for allergy. For example, just they use just cup protein formula, and your patient with atopic dermatitis, and you see the skin rashes and some other symptoms for allergy for cup proteins. You understand that the reason it's only the just cup protein formula. You will discuss with your patient, with parents, transfer to partly or highly hydrolyzed formula, and you will fix this condition. That's why feeding history for pediatric group of patients is very important. Immunization history. Take the vaccines on regular schedule or not. What is the reason for just not regular schedule? Type of vaccine, at which age, any complication, fever, pain, convulsions, rash, pertussis vaccine cause maybe some high temperatures, fever, convulsion, shock, just what the variation of pertussis vaccine just used, time of last vaccine, BCG scar, pay attention to the all lymph nodes for lymph nodes near the BCG scar, and pulp them, just fix their size of BCG scars, and their fix this info in medical history. Development, gross motor, sit, stand, walk or crawl. Fine motor, grasp, move object from hand to hand, and etc. Social development, smile, laugh, speech, vision, hearing, urination, defecation control, at what age it starts, and as for just urine problem during the night, you should fix all night from the birth was wet, or we have a variation between wet and dry night. Family history is also important. Health of parents, brothers and sisters, family history of same illness, family history of chronic disease and infectious disease, family history of unexplained death, order of baby in the family, any illness in the family. It's better to fix the all just information. Sometimes we should discuss some info with parents or also with grandparents, but it's better to pay attention to the just family history also during the conversation. Social history, rural, urban, source of water. Source of water, as you understand, very important for acute gastrointestinal tract disease, for infection, diarrhea. That's why source of water, some level of education and occupation of parents, some crowding index, below 3 is normal, above 3 is crowding, the number of person or number of rooms, and any domestic animals, ventilation, smoking, and sewage is possible. Development. Then you fix all information for development. You should check parental worries about vision, hearing, and development, key development milestones. Previous child have blood and bowel control. Child's temperament, and behavior, sleeping problems, concerns and progress at nursery, at school. Maybe your patient has some problems like dyslexia or some problems with communication with just other child, or some other problems with maybe in a kindergarten. That's why it's better to fix. And look through the personal child health report. So Redevelopmental Skills, a good overview of development skills can be obtained by watching the child play. Once again, you can first of all observe child before conversation and after and during the examination. A few simple toys such as bricks, car door, ball, pencil and paper, some small toys, picture book can be at your desk, and you can give it to the child. If development assessment in the focus of examination, it's advisable to assess this before the physical examination. Or you can cooperate, or you can just first of all auscultate and pulp and just examine patient, and then you fix or have a discussion with patient. You can observe just the normal just playing activity. Okay, look at this. It's just key development milestones. For gross motor, sits unsupported, walks around furniture, walks undate. Fine motor vision, follow face, reaches for toys, grabs with power grip, pick up small objects. Social and emotional and behavioral development, smiles, feeds himself solid food, drinks from a cup, helps with tasks like dressing, and toil trained. Speech, language and hearing, startless to loud noises, coos and waggles, turns head to sounds, says mom, dad, and etc. Understands commands, say words and talks in sentences. Okay, we'll discuss some key. First of all, gross motor. Immobile infant, we have just commando crawl, and after that crawling on all fours, and after that walking toddler. Or we can have only immobile infant, commando crawl, and after that walking toddler. Or we can have immobile infant, bottom shuffling, and toddler without any crawling. That's why you should ask about commando crawl, sit without supporting, and just work and fix the age when it's observed. Gross motor development, median age. Newborn, lips flexed, symmetrical posture, marked head, leg on pulling up, it's newborn. 6-8 weeks, raises head to 45 degrees in prone. 6-8 months, sit without supporting. At 8 months with round back, at 8 months with straight back. 8-9 months crawling. It can be first commando crawling, and after that full just points crawling. For example, about 10 months cruises around furniture, stay with supporting. 12 months walks unsteadily, and 15 months walks steadily. 6 weeks, follows moving object of face by turning the head. 4 months reaches out for toys. 4-6 months palmar grasp. After that pinker grip, and 8 months, 7 months transfer toy from one hand to other, just from left to right, from right to left. 16-18 months makes marks with a crime. 14 months, 4 years tower. 1.5 years free. 2 years 6 tower of fate, or just very transfer tower, just 2.5 years. Breach from a model 3 years. Steps after demonstration 4 years. 2-5 years line, 2 years circle, 3 years cross, 3.5 years square, 4 years triangle, 5 years. You can give crayons or pen or pencil and observe the figure, the ability to draw without seeing how it's done. And can copy, draw after seeing, maybe can be earlier than ability to draw without seeing. Hearing, speech and language development, it's a median age. Of course, we have variety of, if you observe World Health Organization recommendation, you can find the just variation of the age. We discuss median age. Newborn, stateless to loud noises, we can observe spontaneous moral reflexes. 3-4 months just vocalizes, just goo. 7 months turns to soft sounds out of sight. 7-10 months just small words like daddy, mammy, mama, dada, baba, deda. At 8 months sounds used discriminately, and at 10 months sounds used discriminately to parents. 12 months, 2 or 3 words, at 12 months, at the age of 1 year, 10-12 words, 2-3 words should be just the normal, like as for Russian Federation, mama, papa. The other words can be just like BB for car, kiss for just cat, like Afaf for dog. At the age of just 2 years, 24 months, it should be 200 words and just should be sentences with 2 words. For example, give me daddy, хочу кушать, mama дай. Your patient use 2 or more words to make simple phrases. At the age, it's better to fix in your memory 2 years sentences with 2 words, 200 words, and 3 years sentences in 3/4 just and for example, push me fast, daddy. Хочу красное платье, хочу зеленое яблоко, something like this. Social and emotional and behavioral development. Median ages, 6 weeks, smiles, 6-8 months, puts foot in mouth, 10-12 months, waves bye-bye, plays peekaboo. In Russian Federation we named it cuckoo. 12 months, drinks from a cup with 2 hands. 1.5 years, it's 18 months, holds spoon and gets food safely to mouth. 18 to 24 months, symbolic play, just feeding teddy bear or just play with car. 2 years, dry by day, pulls off some clothing. 2.5-3 years, parallel play, interactive play involving and takes just have some variation of communication with our child. Okay, to summarize, developmental milestones by median age. Newborn, flex posture, fix and follows face, stills to voice, stateless to loud noise, smiles by 6 weeks. 7 months, sits without support, transfer objects from hand to hand, turns to voice, polysyllabic, babble, finger feeds, fears strangers. 1 year, stands independently, pincer grip, and 1-2 words in sentence, 10-12 words in just vocabulary. Drinks from cup, waves, and play peekaboo. Just 15-18 months, walks independently, immature grip of pencil, random scribble, about 6-10 words. It's World Health Organization recommendation is for Russian Federation. It's 10-12 words, but at the age of 2 years it's 200 words, but it's about 100. But for this age we fix like words, some voices like BB for car. It's also words. Feeds self with spoon and beginning to help with dressing. 2.5 years, runs and jumps, draws 3-4 word sentences, understands 2 joint commands, parallel play, and clean and dry. Okay, we discussed developmental information. It's better to fix all this for medical history. And after you once again you can try to fix some info during a conversation with parents. Some info you can fix during the just examination and during the playing activity. Okay, gastrointestinal tract history. History of bowel motion, diarrhea. Amount, increased watery of loose in small intestine disease and infections like viral cholera, decreased small and bulky in large intestine disease like colitis. Frequency, high frequency in small intestine disease, low frequency in large intestine disease. Color, normal color, yellow color is normal for newborn baby. Brown or green is for just toddlers, and the group of just pediatric patients. Green color can be or gray color can be for just formula feeding. And green color normal for breastfeeding drugs and some food like spinach or other leafy vegetables. Dark green color from bile. Black color stomach bleeding or food drugs like iron. Red color low gastrointestinal tract bleeding drugs, some foods, and white color is biliary obstruction. Milk only diet and some drugs, for example antacids. Amount, frequency, color. History of bowel motion, diarrhea. Presence blood, intestinal infection, infant colitis, intersuspection, inflammatory bowel disease, antibiotic associated colitis. Presence markers, intersuspection, inflammatory bowel disease, Meckel's verticulum. Consistency, water occur due to viral cholera, loose occur in small bowel disease, firm occur in large bowel disease. Order, not important, or fish order, small intestine disease, infections, fancy order, bacteria, amoebiasis, colic disease, lactose intolerance. Just blood, mucus, consistency, and order. Day or night? Only at night. It can be, for example, fortified. Only day related to feeding. Day and night related to feeding, and its secondary type related to infection like typhoid, tuberculosis, brucellosis. Associated features: colic, fever, sweating, anorexia. Presence of tenesmus occur during or after defecation. Causes: constipation, hemorrhoids, Crohn's disease, anal abscesses, rectal abscesses, diarrhea with vomiting, viral infection, food poisoning, bacterial infection, traveler's diarrhea. It's better to fix, ask colon for if it's traveler's diarrhea, the region, the condition of water, diarrhea with cough, infection, for example, rotavirus, adenovirus, respiratory causes, cystic fibrosis, tuberculosis, some atypical variation of COVID infection. Also, you should pay attention to the all situation when it's diarrhea, vomiting, diarrhea with cough, and some tenesmus. Okay, notes. Viral infection, for example, rotavirus. During the exam, you will have some of them. We'll discuss. Acute gastrointestinal tract infection, and also we will discuss rotavirus during our practical classes. And you have some this question for exam lists, and it's flu-like illness, then vomiting, then diarrhea, and low-grade fever or no fever. Viral cholera, large amount, watery, loose, high frequency. Shigellosis, bloody diarrhea, tenesmus. Fish anemia, fresh, large amount of blood per rectum. Hypokalemia, diarrhea, abdominal distension, weakness. Toddler diarrhea, due to excessive sweets and juice consumption, it's relieved by fasting. Parenteral diarrhea, due to systemic cause rather than gastrointestinal tract, like meningitis, UTI, otitis. How to know parenteral normal general stool culture, source of infection, no infection, cause of diarrhea, metabolic acidosis, acute diarrhea, breath to waste, and secretory diarrhea, not affected by feeding. You should pay all attention to the and just analyze all complaints. Constipation. Onset and duration of decreased bowel motion, frequency of defecation associated with pain, blood, and mess. Fluid intake, type of nutrition, chronic disease like colic, physiological problem, some neurological problem, and any treatment or intervention. Just constipation, the prolong, the frequency of defecation, and you should pay attention to the norm. The frequency of defecation, infants in first year 4 stools per day or after each feeding stool. 1 year of age, 2 stools per day or 1 stool per day. Breastfed infants may not pass stool for several days and be entirely healthy, but it's not, you should just analyze that it's not dyschezia, and also it's not a constipation because some problems during the defecation, just some dryness also can be the variant of constipation. 4 years of age varies from 3 stools per day to 3 stools per week, similar to adults. Definition of constipation is the infrequent passage of dry, ardent fecus after accompanied by straining or pain. There may be abdominal pain which vexes and veins with passage of stool or overflow soiling. Motions or behavior, and the causes of constipation, multifactorials arising connectively on acutely ill young children, precipitated by dehydration, problems with toilet training, unpleasant toilets or stress, Hirschsprung disease, anal abnormalities, anal fissure causing pain, hypothyroidism, hypocalcemia, and treatment, what was prescribed for these patients with constipation, and also pay attention as it's a constipation with for young children or for just infants. It can be the symptoms of carb proteins allergy and intolerance, carb protein intolerance. That's why pay attention to the feeding history also. Vomiting, onset, duration, frequency, amount, color, white, it can be milk, yellow, gastric juice, green bile, constituency content, day or night, projectile or not, aggravated factors, food or just some stress factors, or it can be during the just drive associated with fever, fits, hours. Other features: post-tussive emesis, bile-stained, projectile vomiting, bacterial diarrhea, then vomiting, viral vomiting, then diarrhea, vomiting after eating by 6 hours and fever at night, vomiting after eating by more than 24 hours, vomiting after eating by more than 24 hours. Look at this, the times for prolongation is very important for the etiological factors for vomiting. Definition: possessing non-forceful return of small amounts of milk, vomiting, classes of vomiting: gastroenteritis, feeding problems, ingestion, infection, gastrointestinal tract congenital anomalies, and gastroesophageal reflexes, intestinal obstruction, celiac disease, peptic ulcer, renal failure, raised intracranial pressure, diabetic ketoacidosis, torsion of the testes, and all treatment. For example, as for vomiting, sometimes we prescribe anti-reflux formula, and you should discuss can it help for infant child, or in situation, of course, in situation when it's the reason for vomiting is just allergy for caproteins. Of course, just normal proteins with just that normal size of caprotein in just formula for caprotein anti-reflux formula also can not stop this just disease also. Fever: onset, duration, frequency: continuous fever, intermittent fever, remittent fever, palpitant fever, degree: documented or not. Time: during night, like tuberculosis, which associated with sweating, or during day. Associated with sweating, shivering, rigor. Relieving factors: ask about febrile convulsion and otitis media, presence of rash, illness of our family members, specific illness, recent travel abroad. It's very important for malaria, typhoid. Also nowadays it's also important information for just COVID virus. Increased susceptibility from immunodeficiency. Fever: onset, duration, frequency, degree, time, and some other point. Jordans: onset and duration, in first day or not, color of skin, feeding problem, associated with fever, itching, blood group or child and parents. It's very important for the just hemolytic disease. Blood group, recent blood transfusion, any medication used, recent disease or infection, family history of liver disease, maybe some deaths in early neonatal period because it was some congenital problems, congenital disease with maybe just gallbladder. Physiological Jordans: breastfeeding, internal bleeding, hemorrhage, gluten compatibility, infection, liver malfunction or enzyme deficiency, abnormality of baby's red blood cells, and it's better to fix all analysis. Also some other blockage or problem in the bile ducts and gallbladder for just sepsis. You should discuss it with parents, or maybe once again neonatal period deaths for maybe aunt or maybe for just some other relatives. Abdominal pain: site, onset, character, radiation, associating, time course, exacerbating, and severity. Socrates just use this acronyms. Socrates, site, onset, character, radiation, associations, time course, exacerbating, severity. Okay, that's all for gastrointestinal tract. Transfer to renal history. Amount of urine. Anuria is absence of any urine output. Oliguria is decreased urine output. As for infants, oliguria can occur during the first 24 hours. Oliguria for older child and less than 500 milliliters for body surface. Also, you should pay attention to polyuria. Some common causes of polyuria: polydipsia, soliduriasis like glucosuria, diabetes mellitus, vasopressin or some other deficiency, chronic renal failure with concentration defect, structural malformation of kidneys, then cause polyuria. Color of urine: red. The red color can be caused by hematuria, meaglobinuria, hemoglobinuria, some foods like berries, beets, food coloring, and some drugs. For example, it can be the symptoms when some foods like berries, like some vegetable change the color. It can be this, the color of urine to the red color. It can be the reason for iron deficiency anemia. It can be the symptoms of iron deficiency anemia. That's why then your patient describe you that some vegetable and berries change the color of urine to the red. Occasionally, it's better to prescribe just general blood test. Orange, pyridium, rifampin, urate crystals. Green, food colorings and increased carotene in the diet. Brown or black, hemoglobin, bilirubin, nitrofurands and alkatonuria. Yellow, bile pigments. Blue, methylene blue. Milky or cloudy color, it's cells or bacteria in the urine. In situation then it's just cloudy color or milky color, it's better to prescribe general urine test. And after sitting, urine may form crystals that makes urine appear cloudy. Once again, colors of urine it can be the normal, it's yellow, it's vary from bright yellow to just cloudy, and it's once again it's normal just color, but overhydrated, optimal hydration, still hydrated and doing great. No need to fret, you could be mildly dehydrated or you are definitely dehydrated. Just pay attention to this color and also colors of urine: purple, brown, green, orange, red, bright yellow and pale yellow. Pain. Painful mixture in urinary tract infection, candida infection, pinworms, irritative dermatitis, cystitis, urethritis, or some piscogenic pain. Flank pain, pyelonephritis, or injury, renal colic, stone, and voiding symptoms include poor stream, hesitancy, intermittent flow and straining when passing urine, and causes cystitis, stone in urethra, injury, stricture, and adhesion. Once again, pain, just intensivity, localization of the pain, and what help to just maybe not to fix or maybe to decrease the intensivity of the pain. For example, sometimes bath with warm water help some group of patients with urine tract problem. Storage symptoms include increased frequency and urgency of passing urine, urgent conscience and needing to get up or to pass urine at night, nocturnal aneurysis, and causes of frequency: anxiety, drinking caffeinated beverage or fizzy drinks, emotional upset, having problems with constipation, a frequent urinary tract infection, nerve damage or malfunction that causes a child to have difficulty recognizing a full bladder, refraining from completely emptying the bladder then on the toilet. Some organic causes of nocturnal aneurysm like urinary tract infection, fecal retention, some dysfunction, and in situation of nocturnal aneurysm, you should ask about is it all night wet or just the variation of wet and dry night. It's very important to the differential diagnosis. Okay, cardiorespiratory history. For the cardiorespiratory system, we will discuss respiratory system, and after that we will discuss cardiovascular system, because all this information is very important, but sometimes they combined. One of the most important complaints is cough, onset, and duration. Duration, less than 2 weeks, it's acute situation. 2 weeks, 2 months, it's acute prolonged cough, for example, pertussis or chronic sinusitis. More than 2 months, it's chronic, foreign body, gastrointestinal reflux disease, tracheoesophageal fistula, cystic fibrosis, bronchiectasis, mucociliary dyskinesia. Timing: nocturnal, midnight, early morning, all over the day. For nocturnal, it can be allergy or asthma. At midnight, it's sinusitis. Early morning, bronchiectasis, some chronic bronchitis, adenoid smoking. Exercise, during the exercise, it's asthma. And all over the day, it can be allergy and foreign body. Continuous or intractable. And character: barking, group laryngotracheobronchitis, staccato, chlamydia, pneumonia, and respiratory infection and allergy. Wheezing, it's bronchiolitis and asthma. Paroxysmal, whooping cough, bronchiectasis, or lung injury. Paroxysmal post-tussive vomiting, it's pertussis. That's why the character, timing, duration, and continuous or intractable. And it's better what will help your patient. For example, if it's a problem with allergy, just avoid some allergen and use some short-acting beta agonist, or maybe using some inhaled corticosteroids. For example, if it's just chlamydia, pneumonia, or if it's obstructive bronchitis, maybe some short-acting beta agonist, or once again inhaled corticosteroids. Different size, and try to analyze the all information with during the conversation with your patient. Okay, wet or dry. If productive, with sputum, ask about color, amount, consistency, contains blood or clot. Wet cough, lower respiratory tract problem. Dry cough, upper respiratory tract problem. Important points: foreign body aspiration for child 6 months to 6 years. Recent infection, allergy, and atopic family. Associated symptoms: runny nose, sore throat, fever, it's non-specific disease. Headache, itchy eyes, sore throat, it's postnasal drip. Wheezing and cough with exertion, it's asthma. Night sweats, tuberculosis. Spitting up, irritability or itching of the back after feeding, infant, gastroesophageal reflux disease. Feeding problem may suggest tracheoesophageal fistula. Of course, as for tracheoesophageal fistula, your patient age will be infant or just early neonatal period. Of course, but it depends. for this on the size, but it's toddlers or infant. Abdominal pain, it can be bacterial pneumonia, weight loss or poor weight gain or foul smelling stools, cystic fibrosis, muscle soreness, viral illness or atypical pneumonia. Once again, cough, wet or dry, important points, and some other associated symptoms, analyze them. Cough. Cough caused by stimulation of nerve receptor in the pharynx, larynx, trachea, and large bronchi. Cough center located in medulla oblongata. For most children, episodes of cough are due to upper respiratory tract infection caused by the common cold viruses and do not indicate the presence of a long-term or serious underlying respiratory disease. Causes of recurrent or persistent cough. Recurrent respiratory infection, post-specific respiratory infection, pertussis, RSV, mycoplasma, asthma, suppurative lung disease, recurrent aspiration. It's plus minus gastroesophageal reflexes, but aspiration. Persistent endobronchial infection, inhaled foreign body, cigarette smoking, active or passive, of course, if it's school age and teenagers. Ask about smoking, electron variants of cigarettes, just normal cigarettes, or maybe some other variants that can be inhaled. Sorry, I forgot the term for kalyan in English, just some other variants for just inhaled situation. For tuberculosis, habit cough and airway anomalies, tracheobronchial malacia, tracheoesophageal fissure, just ask about all red flags. Shortness of breath, onset, duration, day or night, degree, aggravating and relieving factors, associated symptoms bluish, discoloration, fever, sweating, abdominal pain, first time or have similar attack previously, known case of cardio or respiratory disease, common causes of shortness of breath in children, phonology, foreign body in upper airway, enlarged tonsils, asthma, respiratory tract infection, obesity, congenital cyanotic heart disease. Noisy breathing, onset, duration, frequency, once again, continuous or not, character of sound, day or night, related to allergy, relation to feeding and sleeping, any deformity in nose or respiratory tract. Chest pain, quality, intensity, location. Can they point to location with one finger? Because then it's palm, it can just catch two lungs and trachea, just one finger and can it point. Radiation, timing of the pain with relationships to exercise or eating. Don't forget about gastroesophageal reflux disease and after eating, or also don't forget about peptic ulcer, duration, frequency. Ask about any history of trauma, because some sport traumas can cause the chest pain. It can be just some broken ribs, or it also can be some some other variants of traumas. What do they think is causing the pain? Any recent stressors at home or school or problems with anxiety? Common causes of chest pain in children: cardiac, musculoskeletal, fractured rib, muscle strain, respiratory, asthma, foreign body and airways, chronic cough, pleural effusion, gastrointestinal tract, esophagitis, gastroesophageal reflux disease, and non-organic anxiety and stress. Bluish discoloration, duration, side skin, mucous membrane, central or peripheral, lips, tip of tongue, peripheries, respiratory or cardiac disease, any congenital anomalies, associated symptoms, cough or shortness of the breath. Once again, shortness of the breath can be varized with bluish discoloration, any drug use, exposure to cold, previous same condition, and notes about respiratory causes, respiratory distress syndrome, asthma, pneumonia, pneumothorax, bronchitis, lung abscess, cystic fibrosis, asbestosis, and some are familial. Cardiac disorders, acute cyanosis can be pneumonia, chronic cyanosis, pathology of follow, signs of chronic cyanosis, and as for acute cyanosis, it's a response to the just oxygen, and for pathology of follow, it's not respond to oxygen. Signs of chronic cyanosis, finger clubbing, polycythemia, and gingival hyperplasia, and acrocyanosis occur in a normal baby during the just examination. Palpitation, onset, duration, frequency, character, told mother to tap it on the table, relation to feeding or activity, presence of fever, any cardiac problem, and use of any drug. Sentinel system history. During this examination, it's better to pay attention to the central nervous system, and don't forget about some maybe red flags from peripheral nervous system also. Headache. Headache onset, duration and severity, site, aggravating and relieving factors, associated symptoms, family history of migraines, medication history, and history of trauma. Factors that may have participated in the headache, most often migraine. Notes: causes of headache, migraine headache, tension headache, cluster headache, sinus headache, head trauma-related headache, intracranial mass-related headache, benign intracranial palpitation, meningeal irritation, and medication Aneurysis headache. In migraine attack, ask about onset and timing, number of attacks per month, aggravating and relieving factors, medication, aura, eating contraindicated substances, treatment of headache, elimination of identified precipitants, lifestyle changes, stress relief, or drugs, analgesics, triptans, isomethamphetamine, ergotamines, and abnormal body movements. For pediatric group of patients, not a very rare situation. Number of movements is diminished. Age of onset, full-term neonate, infant, older child. Sex, female and male, their etiological factors, look at this, they are just varied. Onset and duration, acute and slowly progressive. Change of the time, type of movement, rapid jerky, slow movement, atetosis, sustained dystonia, involvement of body parts, distal limb, atetosis, all body parts, and focal dystonia. Presences of movements in sleep, seizure disorder, nocturnal melancholy. Associated symptoms, loss of consciousness and cyanosis. Aggravating factors, relieving factors, and differentiated it from brief holding attack and pseudoepilepsy. And family history of a similar or related condition. And also for just abnormal body movements, for acute rheumatic fever, it's very important. Previous infection disease such as scarlet fever, tonsillitis, and sometimes some other infection disease, tonsillitis, sinusitis that was caused with special infection agent. Convulsion, precipitation, description, duration, number of attacks, associated with tongue beat and unconsciousness, stoppage, post-ictal state, presences of fever or infection, previous episodes, family history, head trauma, sentinel sister disease, and developmental milestone. Once again, convulsion, precipitant, description, duration, number of attacks, post-ictal states, previous episodes, family history, trauma, some disease, and some milestone. Loss of consciousness, duration, frequency, and aggravating factors, body color, pale or bluish, abnormal movements, unconsciousness, take drugs, some disease, central nervous system disease, any fit, loss of consciousness, generalized epilepsy until proven otherwise, focal abnormal movement, loss of consciousness, partial epilepsy, some other symptoms like visual or hearing problems, diplopia, due to increased intracranial pressure for any cause, numbness, unilateral, bilateral, symmetrical, asymmetrical, hemiplegia, monoplegia, tetraplegia. These other symptoms is also very important to differential diagnosis. Okay, for discussion for our information of sorry, just a minute. History question. Identification, date of admission, date of examination, chief complaint, history of present illness, and examination for all system and all system that we discussed. For this lecture we just ended. I will give you 5 minutes to prepare for the second lecture, and we will start our second lecture maybe in 5 minutes. Thank you for your attention. Wait for the next lecture.